Today's topic is male infertility. Dr. Bilkis, I am audible to you. You have to mute yourself and then you can speak. So, today's topic is male infertility, a social stigma. What are the causes of male infertility? The causes of male infertility are pretesticular, testicular, and post-testicular. How can you differentiate? This is a figure that very well we can understood. The causes are pretesticular means hypogonadotrophic hypogonadism. What is that? As we learned in the ovarian pathology, main two hormones are FSH and LH secreted from anterior pituitary and that were activated by stimulated by the GnRH, gonadotrophin releasing hormone. Same way in the male, if due to pituitary tumor or due to idiopathic origin, sometimes what happens? There is a absent GnRH secretion. So absent LH FSH secretion or very low FSH LH secretion. LH is a male androgenic hormone that is required for androgen, means that is the main hormone that is for production of testosterone, and FSH is main for formation of the sperm. It helps in the spermatogenesis. So for the normal sperm functioning, FSH and LH should be in a balanced amount. So the causes of pretesticular are hypogonadotrophic hypogonadism, insufficient GnRH secretion and insufficient FSH-LH secretion. It occurs in idiopathic cases as well as certain genetic disease like Coleman syndrome and in coital dysfunction like erectile dysfunction are the causes of pretesticular. Then a testicular means problem is at testis level. Suppose FSH and LH, some problem happening at testis level like increased temperature in pampiniform plexus, varicocele. 70% of male infertility are mainly due to varicocele. Second is testicular failure. Very high FSH and LH, very high level that sperm production is completely stopped. Like ovarian failure we had discussed, very high FSH LH leads to ovarian failure. Here, very high FSH and LH leads to testicular failure. And the post-testicular are problem in outflow tract, means ejaculatory duct obstruction, vas deferens absent are main causes with post-testicular. So causes of pretesticular are hypogonadotrophic hypogonadism, genetic abnormality, Coleman syndrome and coital disorder are caused pretesticular. Testicular means testicular failure. Varicocele is the commonest cause and post-testicular is ejaculatory duct obstruction, means outflow obstruction is the cause for post-testicular. Everyone understood the causes of male infertility? The most common cause for male infertility is varicocele. Varicocele is the most commonest cause for male infertility. Others are obstructive cause, immunological, genetic, endocrinal, idiopathic and coital disorders. Lifestyle factors like obesity, smoking, More laptop and mobile usage, tight underwear are also leads to male infertility. How will you evaluate? To take a proper history of male partner also. Take a proper detailed history of male partner and do the examination. Take a detailed history of family fertility history, sexual history means frequency of intercourse, libido, any signs of erectile dysfunction, ejaculation. Take a proper medical history, history of diabetes, hypertension, respiratory disorder, liver disorder, STD, UTI, surgical history, vasectomy, testicular surgeries, because all of these surgeries, if happen to that person, they also affect the sperm function. Also ask about the history of any chemotherapy and the radiation, because sometimes patient won't feel that they should inform you that they had undergone for chemo and radiotherapy for any disease in the past, but it may affect the sperm function. Then also ask the childhood history of the mumps or any viral fever, because sometimes certain viral infection like a mumps or orchitis can lead to the testicular failure. Then the also ask for the occupational and environmental history in the form of exposure to the heat, toxins, dyes and tannins. Family history ask for infertility, recurrent pregnancy loss, congenital birth defects and etc. Examination, scrotal examination and testicular examination is done to note the size and the volume of the testes. Abdominal examination to see for undescended testes. The most common investigations we offer for male infertility is mainly first is semen analysis, second is hormonal evaluation, FSH, LH, testosterone and the prolactin, other genetic testing for karyotyping, Y microsome deletion required the chromosomal analysis. Now the semen analysis. Semen analysis is the most important thing that we going to see in male infertility. So in the male infertility or whatever the cause, the first most common investigations we offered to them is the semen examination. So at least you should learn what you will going to watch for semen examination, because many pathology have different kinds of protocols to read for semen analysis. But from my point of view, what you will going to see in semen analysis is check for volume, liquefaction, number of total number of sperm per 1 ml ejaculation, motility of the sperm and fructose taste, and also check for if any pus cells are present or not. These are the main factors you are going to see for the male infertility. The volume could be 1.5 to 3 ml. Check for liquefaction time. What do you mean by liquefaction? Because what happened? The ejaculated semen sample is non-liquefied. So you cannot make a drop. Ideal liquefaction time is, liquefaction means separation of the sperm. So ideal liquefaction time is less than 30 minutes. Semen should be liquefied within 60 minutes. If more than 60 minutes semen remains non-liquefied, that is the cause of deficiency of the prostate enzyme. So it is very important to check for liquefaction. How will you check? Take a pipette, micro pipette and hold the semen. It should be put drop by drop. If it is put drop by drop, then this sample is liquefied. If the sample is not liquefied even after the 1 hour, that means chances of conception are very less. So that can you removed with the help of first try to give the antibiotics and some anti-inflammatory drugs and still not improve, then you can correct it with the help of IUI. Because in intrauterine insemination, we do the semen washing. So by pipetting, we can remove that factor and we get the yield of uh, motile sperm. So check for liquefaction. Then second point is you going to check is sperm concentration. Sperm concentration always check for per ml, not for ejaculate, per ml. So ideal sperm concentration should be more than or equal to 20 million. 20 million sperm should be there. This I am going to tell you about my practical criteria, because WHO and everything are going to change by change. But this is the personal experience what we are following in our clinic is, if the count is more than 20 million per ml, we will give them a natural try. Then the motility. Motility, there are 4 grades. Every laboratory will write in a different pattern. Some will write as a grade 1, grade 2, grade 3, grade 4. Someone write as a motile, highly motile, aggressive motile, active motile, then sluggish motile and non-motile. So basically they are divided into 1, 2, 3, 4. Combined 1 and 2, grade 1 and grade 2, motility should be more than 25% for normal conception. So if the count is more than 20 million and motility is more than 25%, the semen is considered as a normal. Then check for fructose test. If fructose test absent, means it suggests ejaculatory duct obstruction. And also check for pus cells. Normal 2 to 3 pus cells are okay. But if the pus cells are more than that, that patient required antibiotic. Usually, antibiotic should be given after doing semen culture and sensitivity. But prophylactically, we usually give capsule doxycycline 1 BD for 21 days if there is a pyospermia. So this is how we read the semen part and we took the decision what to do. If you want to write in your book, you can write. There is a criteria made up by at our center. If the patient count is more than 20 million and motility is more than 25%, then medical treatment, we assuming female part is everything okay. Then if the count is between 10 to 20 million and motility between 15 to 25%, patient required IUI, intrauterine insemination. But if the count is less than 10 million and motility less than 15%, that is the ideal candidate to go for IVF, in vitro fertilization. I hope everyone understood this bifurcation. Any doubt? You want to ask a question? Okay. Then certain terminologies. When you called oligospermia, when you called asthenospermia, when you called teratozoospermia, and when you called Ott syndrome. What is oligospermia? When the sperm count is less than 20 million per ml, it is called oligospermia. When the motility is low, it is called asthenospermia. When morphology is affected, it is called teratozoospermia. And combined of 3, oligoasthenoteratozoospermia syndrome, that is called Ott syndrome. And one is azoospermia, means no sperm in the semen. So these are the basic terminologies we used in the practice. Then the azoospermia. Suppose if you carried out the semen examination and you found that there is a no sperm in the semen. So on the first report, you can't blame or you can't tell the patient that you are azoospermic. To label the azoospermia, at least three samples at a 15 days apart should be carried out, and all three samples, if they said it's a azoospermia, then you can declare that patient as a azoospermia and then send them for the further evaluation. Now the diagnosis. The first step we learned is semen examination. Then if we have any doubt or low sperm or absent sperm or azoospermia, then we carried out the hormonal evaluation. Normal FSH and LH should be more than 8. That we did, the value is as equal to the female part, as a female. Testosterone should be more than 300 nanogram per dl. If there is a prolactin level should be less than 25. If there is a hyperprolactinemia, it leads to erectile dysfunction. Also check for the TSH, signs of hypothyroidism and hyperthyroidism. So this is one table. Suppose there is a patient, as we discussed, post-testicular, pre-testicular and testicular. So if increased FSH and LH means testicular cause, it is called testicular failure. If increased FSH and normal LH, it is called failure of spermatogenesis, means testicular failure. And decreased FSH and decreased LH means pre-testicular failure. So this how we differentiate. So if there is a testicular failure, you get FSH LH high. If you get spermatogenesis failure, where high FSH but normal LH, and in pretesticular like hypogonadotrophic hypogonadism, both FSH and LH are low. Everyone understood this? Dr. Bilkis, you want to ask any question? Then if you have doubt, first is semen examination, second is hormonal evaluation, and third is genetic evaluation. So if you have any doubt regarding genetic abnormality, you can carry out chromosomal study, that is called chromosomal study of male. So you can find out if there is any genetic disorder like the Klinefelter syndrome, Y-chromosome, microsome deletion. You can differentiate and take a decision. Others investigation. So we learned yet three investigation. First is semen examination. Second one is blood investigations for hormonal profile. And third one is chromosome analysis. The rest investigations are USG scrotal to rule out varicocele. Testicular biopsy, if there is azoospermia, we can do the biopsy to rule out whether the sperm is present or not. Now comes to the management part. What is the management in male infertility? The basic management divided into three parts: medical, surgical and the ART technique. Medical management depending on the problem. Suppose, as I told you, if there is a liquefaction problem, then you can give antibiotics and anti-inflammatory and still not relieved, go advice for IUI. If you find If you found pyospermia, then better to send semen sample for culture and sensitivity and give antibiotics accordingly. Or sometimes we can give the prophylactic antibiotics. If there is a low FSH and LH, Dr. Bilkis, you want to ask a question? You have raised the hand, Dr. Bilkis. Yeah, I can hear you. Please, you want to? Hmm. Yeah, I am hearing you. Yeah, I am hearing you. Yeah. Okay, okay. So if you want to ask, yeah, yeah. Trypsin and chymotrypsin. Trypsin and chymotrypsin. Anti-inflammatory, yeah, 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 okay. Trypsin and chymotrypsin. Okay, okay. Sometimes there is a hypo cause, that is the pretesticular cause. So in that we can give gonadotropins injection to enhance the FSH and the LH level. We can in certain cases we give clomiphene citrate to increase the count, that we will going to learn further. Then antioxidant has the main role, because 60 to 70% male infertility are mainly due to idiopathic or the environmental cause or the overusage of the mobile phone and etc. So this is mainly due to oxidative stress leads to the male infertility. So antioxidants play a very vital role in case of the male infertility. Nutraceutical, as we discussed, antioxidants play very important role in male infertility. So it is mainly given to improve the count, motility and the morphology of the sperm. It increases the rate of the spontaneous conception, lowers the rate of miscarriage due to DNA abnormality in the sperm. Surgical management we are not going to discuss, as this is usually carried out by the urologist and the andrologist. Mainly surgical treatment is done for the ejaculatory duct obstruction and varicocele operation. But in my practice, I had seen that varicocele surgery doesn't give rise to the any improvement in the sperm and the count. Though many surgeons advised surgery for varicocele, but since 15 years I am doing infertility practice, I am not sure that surgical treatment for varicocele increase the count. Then, in certain cases, we required to go for ART techniques, that is ICSI, that is intracytoplasmic sperm injection. So, whenever there is a count is very low, then in ICSI, what is ICSI? We took a like, this is there is a machine where inverted microscope is there. In that machine there are two needles are there. One needle hold the egg, this is the M2 egg, and one needle hold the sperm. Now gradually this sperm is to be injected into the egg, that is called ICSI, intracytoplasmic sperm injection. Where count is very low, then ICSI is advisable. PISA is peri-epididymal sperm aspiration. When we have a doubt that there is some testicular failure or problem, we can do the peri-epididymal sperm aspiration, and we may get sperm, and then we can go for the ART technique. TISA means testicular epididymal sperm aspiration. First always we do the PISA. If we don't get the result from PISA, we can take a biopsy from the TISA. Micro TISA, there is one uh, microscope instrument is available for micro TISA technique, where special light they put, and they can say that here is the sperm, is this in the seminiferous tubule. So we take out the seminiferous tubule, dissect it and retrieve the sperm for micro TISA. If all the factors above are failed, then we can do the AID, that is called donor insemination. The medicine that we going to discuss in the medicine part, but for male infertility I am going to tell you the treatment that we will again discuss in the all medication part also. But usually in my practice, what we give the treatment for male infertility are, we usually first I always to check for semen analysis. If count is more than 20 million and more than 25%, it is okay. But sometimes what happens, count is high but motility is low. It is mainly indicating of oxidative stress. So in that case, we usually give good antioxidants. What is good antioxidants? The antioxidants which includes especially coenzyme Q10. Coenzyme Q10 ideally 300 milligram per day should be given to treat the male infertility. Coenzyme Q10 300 milligram, lycopene 2500 microgram, astaxanthin, omega 3 fatty acid, vitamin D and other multivitamins and the minerals, especially zinc and the selenium. These are the main factors which those having the good antioxidants and all these multivitamin and minerals, we usually give them for 3 months. Always any treatment for nutraceuticals you have to give for 3 months, whole 3 months, because the whole spermatogenesis takes a 90 days to develop a sperm. So if you give this to relieve the oxidative stress, you can get the result only and only after 90 days. So that's why explain the patient this medication you have to take for 90 days. Suppose if the count is, if there is a very mild problem, then we can give once a day, or if major, then we can give one BD. Sir, in sometimes there is a count problem. There is a 15-16 million like count is there. So we can add the clomiphene citrate 25 milligram, one at a bed time for 3 months. Usual regimen to give clomiphene is 25 days clomiphene, 5 days off, again 25 days clomiphene, 5 days off, again 25 days clomiphene, 5 days off. So 75 total clomiphene tablets to be given for improvement of the count. This is the basic method or we going to treat for male infertility. Good amount of antioxidants, mainly coenzyme Q10, lycopene, astaxanthin, omega 3 fatty acid, vitamin B12, vitamin D and other zinc, selenium, and along with clomiphene for increase the count 25 milligram 3 cycles. Then we can treat according to the problem. As I told you, if there is a problem of infection, then give the antibiotics. If liquefaction problem, give antibiotics and anti-inflammatory. Not, then IUI. If there is a hypo, chances of result with medication with this treatment is very less. But if the patient wants to take a chance, we usually give HMG HCG combination. How we can give? We give 2 injection 150 IM of HMG. What is HMG? HMG is gonadotropin injection which contains the mixture of FSH and LH. So 150 IU HMG injection twice a week. Suppose we give on Monday and Friday, and on Wednesday I will give 1 dose of injection HCG. So Monday HMG, Wednesday HCG, human chorionic gonadotropin hormone 5000 international unit, and again on Friday 150 HMG. Like this way we repeat up to 3 months, and then we can carry out again a report to check result is there or not. So this way how we usually treat the male infertility. You have any doubt, then can ask a question. Dr. Bilkis, you want to ask question? Yeah, please. Okay, fine. Any other? Dr. Sonal, Dr. Ram, you want to ask a question regarding up to this? Any other you want to ask a question? So let me show the medications, especially male infertility. So you can get a very well idea that is available in another presentation. So let me show you that all medications. So you have a proper idea. Okay. See, this is the you can see screen. Screen is visible to you. Hello, you can, yeah. So this is HMG injection, manotropin injection, which contains both FSH and the LH that usually we give in hypogonadotrophic hypogonadism condition. Two injection twice a week. So this is a basically HMG injection. Then combined with HCG, here this is the HCG, human chorionic highly purified chorionic gonadotrophin hormone, 5000 IU along with HMG. So twice a week HMG and once a week HCG, ऐसे 3 cycles. Then this is the ideal combinations to treat the male infertility, which contains coenzyme Q10, L-carnitine, astaxanthin, lycopene, cyanocobalamin and all vitamins and the minerals. So this type of combination is usually preferred to treat the as antioxidant for male infertility. So keep remember this when you select any good antioxidant, then keep mind all these should be present in an adequate amount. Coenzyme Q10 ideal dose is 300 milligram for male infertility, but many of the tablets and the medications it can be available in the sachets form, but they are available in a very mild form. So when you prescribe any medication for male infertility, check the dose of coenzyme Q10. Ideally minimum it should be 100 milligram. As I told you, it is ideal dose 300, but 100 से भी कम है, then there is a you nothing given to that patient. Then one is clomiphene citrate, that is I don't know here. This is the clomiphene citrate, CCQ25. This is the clomiphene citrate with ubiquinol. It is one kind of antioxidant. So CCQ25, one tablet for 25 days, like a 3 cycles we give to treat the increase the count. Okay. So here I completed male infertility. From tomorrow we will discuss the oral medications that commonly used to treat the male infertility. So tomorrow we will going to discuss about clomiphene citrate, letrozole, little bit about the gonadotrophins and all the medications that treatment of PCOD, treatment of adenomyosis. So all the individual treatment the and all routine medications used for male infertility. So tomorrow we will going to discuss the medication part. Okay. Have you any question? Or I shall end the meeting. Any questions or any doubt from all of you? Okay. So meet tomorrow. The one request I want to, tomorrow, from tomorrow onwards, 5 p.m. is okay with all of you? Dr. Bilkis, Dr. Ram and Dr. Sonal. Hello, I am audible? Dr. Sonal, tomorrow 5 p.m. will be okay for you? Okay. Dr. Ram, 5 p.m. is okay with you? Dr. Bilkis, tomorrow 5 p.m. Indian Standard Time. Okay. So from tomorrow we will do. Okay. So from tomorrow we will do 5 p.m. Infertility class. Okay. Okay. Bye bye. Have a nice time.